morning, everyone. I'm going to talk about procalcitonin guidance for optimal antibiotic therapy in critically ill patients. My name is Márton Papp. I'm an anesthesiologist and I'm working in St. John's Hospital. My vision is that the overuse of antibiotics and the rate of adverse events will decrease abruptly. And to achieve this, my mission is to protocolize and individualize the best way to use procalcitonin in clinical practice. These are my specific goals. My first goal is to investigate the effects of procalcitonin-guided antibiotic therapy versus standard treatment in ICU patients with the methodology of meta-analysis. The problem is that the inappropriate use of antibiotics has serious adverse effects like dysbiosis, Clostridioides difficile infection, emerging antimicrobial resistance, and our ICU patients are at a high risk of getting an infection caused by a multi-drug resistant organism. On the other hand, the current surviving sepsis guideline recommends us to give antibiotics immediately, but ideally within 1 hour. We can reduce the duration of antibiotic treatment with the use of procalcitonin with a median of 2 days. But despite some positive studies, it is still unclear when to stop antibiotics safely and whether PCT-guided management can serve this purpose. So our aim is to investigate the effects and safety of PCT-guided management versus standard treatment on appropriateness and length of antibiotic therapy. So our question is that, does procalcitonin-guided antibiotic therapy reduce the total use and length of antibiotic treatment without causing harm in ICU patients? So our population is adult patients treated with antibiotics in the ICU. We are comparing PCT-guided antibiotic therapy with standard of care without PCT guidance, and our outcomes are length of antibiotic therapy, rate of recurrent infection, length of ICU stay, cost, and mortality. And we hypothesize that PCT-guided antibiotic therapy reduces the antibiotic usage without compromising patient outcomes compared to usual care. So with this management, we can decrease antibiotic use, antibiotic-associated adverse events, and even healthcare costs without causing adverse effects. We conducted a systematic search in these databases with these results. We have just finished the full text selection, and we are about to start the data extraction. And my second goal is to investigate PCT kinetics to guide antibiotic therapy of ICU patients with suspected new onset infection with the methodology of a randomized control trial. We know that every second ICU patient considered as infected, and infection can more than double ICU mortality. On the other hand, less than 60% of ICU patients with the initial diagnosis of sepsis are later confirmed to have infection. So it is very difficult sometimes to diagnose and treat these infections. We know that procalcitonin is the best known sepsis biomarker. Even after prolonged ICU stay, we can use it to help our decisions. But we can use either absolute PCT values or the kinetics of PCT, and we don't know which one is a better predictor of infection. So our aim is to investigate whether antibiotic initiation guided by PCT kinetics can decrease unnecessary antibiotic therapy compared to using absolute PCT values or no PCT at all. So the question is, can we decrease the use of clinically unnecessary antibiotics with the help of PCT kinetics in ICU patients? So we are recruiting adult ICU patients with suspected new onset infection, and we have an intervention antibiotic initiation using PCT kinetics, comparator 1 antibiotic initiation using absolute PCT values, and in comparator 2 we are not using PCT and our antibiotic guidance, and our outcomes are listed here: rate of unnecessary antibiotic therapy and the same outcomes as I mentioned before. And our hypothesis is that if we use PCT kinetics, we can reduce the rate of unnecessary antibiotic therapy without compromising patient outcomes compared to using absolute PCT values or usual care only. Hereby we can decrease the antibiotic use and antibiotic associated adverse events. We would like to include adult ICU patients with new onset infection, and we would like to exclude patients with long-term or very short-term antibiotic therapy, antibiotic prophylaxis, and with conditions that could highly alter PCT values. just to understand better, for the first step, if there is alarming signs of an infection, for example, the patient has fever, there is a new infiltrate on chest X-ray, etc., and we suspect, highly suspect, or know the source of infection, we have to think about giving antibiotics. Parallel with surgical source control, we are giving the antibiotics. If the patient is hemodynamically unstable, so if the patient is in septic shock, we don't have time. We have to give antibiotics. The guideline tells us to do so. But if the patient is hemodynamically stable, we randomize the patient. In arm A, we are starting antibiotic depending on procalcitonin kinetics. If PCT is increasing with more than 90% from the previous day value. In arm B, we start antibiotic depending on the absolute PCT value if it is more than 0.5 nanograms per milliliter. In arm C, we are not using PCT measurement in our decision making. And after 72 hours, we reassess the antibiotic therapy. Is it necessary? It is an interdisciplinary decision between an intensivist and 1 or 2 infectologists. And if the antibiotic therapy is unnecessary, we stop it. If it is necessary, we continue with it, and later we stop it with using another PCT guidance for all the 3 arms. Here you can see the summary. In arm A, we are using PCT kinetics. In arm B, we are using absolute PCT values. In arm C, we are not using procalcitonin. The outcomes are rate of unnecessary antibiotic therapy. This is the most important. And length of antibiotic therapy, rate of recurrent infection as a safety measure, organ dysfunction, ICU, and in-hospital mortality. Here you can see my goals, which I can use to protocolize and individualize this procalcitonin guidance in clinical practice. And my quote, what is true for every aspect of our lives, he who fights can lose, he who doesn't fight has already lost. Thank you for your attention.
So thank you for your presentation and congratulations for that. Regarding your second project, as far as I understand, these are new onset ICU infections, so basically nosocomial infections, or do you plan to accept patients from the emergency departments or from outside with a novel onset infection?
That's a very good question, both of them. So every new onset infection, let it be when we are admitting the patient from, for example, you from the emergency department, or we are facing with a nosocomial infection in our ICU patients who are at the ICU. Yeah, so both of them. So the point is we have to talk, we have to make an interdisciplinary discussion with ED specialists and other colleagues that use procalcitonin, and it would help our work. But this project is in the first stages in the discussion. But I think we should do that, and we should make it.
And that brings up a second question of mine. So if you accept patients, for example, from the emergency department, I can only talk about that. So the recent guidelines say that we have to start antibiotics as soon as we can if we suspect sepsis.
Yes, the guideline, the surviving sepsis guideline says with strong recommendation, weak quality of evidence, to septic shock patients. But if the patient is not in shock, you can see the guideline that there is a 3-hour bundle that you have some time to think about that. Do I really want to? Do I really have to give antibiotics? Because what we don't think sometimes that we can hurt as much or more with giving antibiotics unnecessarily than giving antibiotics. So this is why we made this protocol this way, that if the patient is in septic shock, we don't have time to think, we give antibiotics. If the patient is not in shock, we have some time.
Thank you for your great presentation. I would like to ask one thing about the second project. So how are you going to use the PCT kinetics at a emergent admission if the patient is not in septic shock? So will you randomize the patient to another arm, or how will you use the kinetics if you have the first PCT done by yourself?
If we have the first PCT on admission in the ICU, and if the patient is stable, we have some time, and we are thinking about that. Maybe if the patient is stable, we should wait for about 12 hours, make a PCT labor test, and regarding that we make a decision about starting antibiotics.
And one more question to this. How often do you plan to measure PCT?
We plan to measure it daily.
Daily, okay.
Yeah.
Thanks.
So I was wondering about the rationale behind the more than 90% elevation of the PCT day by day.
There are two big observational studies which examine that, and in one of them they had this 90%, exactly 88% increase of PCT with a very good area under the curve for diagnosing infection. It was one of my supervisors, Trási Domonkos study, and there is another study that they saw that if there is a double change from the previous day PCT, it significantly tells you that there is an infection. But it is under discussion. I just wrote something, but we have these two studies, and we will think about that later, of course.